So I sort of pushed him into getting me here and putting my point across in the hope that it would help others as well. So one thing which really stuck me about Dr. Vimal was that throughout our journey with somebody in the family, we kept asking him to put a name to the problem that the child was going through, because sort of that would relieve us, or we would know what the child was going through. But he kept telling us that no, don't put any name to the problem, just go with the flow. And I think that was a very big thing. It's like, suppose we have some physical problem, like suppose I have a diabetes, and the doctor, so when I go to a doctor, like I remember I had some issue and I went to the doctor and he said, what do you expect from me? I said, just diagnose my disease. So that sort of gives you a relief. But Dr. Vimal said, no, don't give any name to it. So I think that gave us a lot of hope. Since there wasn't any name that was put to the problem that we were going through, so it gave us a lot of hope that maybe we'll overcome the problem, which I think was a fabulous and a fantastic thing. And then we started on the journey of trying to help the child. The entire family got together. So another thing that I would like to share is that the family plays a very, very important role. Because the person who's going through it, the immediate family, sort of just loses their mental, their stability. They don't know what they're going through. So when the others come around and they sort of help them and guide the child or whoever's going through that problem, it gives a lot of support to the people going through it. So the extended family, I mean, as a novice, as somebody who doesn't have any professional knowledge, I feel the family plays a very important role. So the family family means it included everybody in the family, all ranks. So they did a lot of counseling and they set a lot of rules and a lot of regulations the child had to follow. And extreme patience. I mean, the entire family had to keep a lot of patience. And Dr. Vimal always kept telling us that you need a lot of patience. So that really helped us a lot, and slowly things started to improve, and the child now is as normal as any child of that generation. Professionally, the child is fantastic. He's much sought after and doing fabulously well. The interpersonal relations, which were like really low at that point of time, are absolutely normal. And in fact, yesterday I had attended a small session and just to get the feel of the place, because I was really nervous. I didn't know where I'm supposed to talk. So this person mentioned about the trajectory yesterday, how the trajectory can change if the person gets the right advice or the right medication. So the experience that I'm sharing, the trajectory was amazing. I mean, from somebody who was like in the doldrums, who we thought wouldn't survive, who was like in the negatives, is like, amongst the top few now. So I feel the right care and the right advice completely saves a life. And well, that's about it. That's the experience that I wanted to share, because I was so happy that we thought we'd lost somebody, but we got the person back. So I wish it helps others as well. So that's about it. Thank you.
Thank you, Rashna. Thank you very much for coming and sharing your experience with us. This is very telling. Do you mind taking any questions? Please come all the way, sharing her experience here in your family, yes?
Yes.
About a child who, had some problems, mental health problems, issues, behavior, and with time things improved. Whatever it has helped. And we don't need to find out the details. Any comment from the audience here or questions? Please.
What I will like to ask is not for the speaker. My question is not for the speaker, but for everybody here. Whether the child is like the scenario that the child that has been described in the scenario here, whether the child is suffering from some
psychiatric diagnosis? Like, is that child to be given some psychiatric diagnosis, or is it the is it the issue with the educational system which drives which leads to such high levels of stress in the children? So yeah, that's my question. Like, whether it's a if the kind of behavior the child was having, whether it was a psychiatric diagnosis or whether it was the issues with the educational system which leads to high level of stress.
Well, let me answer it. I mean, of course, they're experts here, but I feel the education system has a lot to blame for it. So it's like everything, it probably began with the education system, with the stress the child going through, and then I think everything sort of, became double, and lots of things getting together, and the child getting into a web. So I think, yes, the stress and everything, yeah.
So whether we should call this kind of stressful situation a psychiatric diagnosis, or whether it's just a response to a scenario a human is facing?
I mean, of course, one should say that diagnosis is essential, but it's never 100% clear, and we don't want to put a label which is stigmatizing, and it's understandable. But at the end of the day, we have to make a diagnosis that will guide treatment, needless to say. But it's about the issue of involving families in the care, whether it's a child or adult or elderly, is essential.
Yeah.
And in Europe, where perhaps we have evolved into less family-centric society or culture versus the East, I come from the Middle East, India here. Role of family is always crucial and important, and impact on family is huge. So the families need support. And in fact, now Mental Health Trust in South West London, we have a carer assessment. I mean, identify the main carer for the individual, be it a child or adult or elderly, and have a full assessment to see what their needs are, how they could be best supported.
In fact, after the experience that we went through, there are a lot of people who come to you and say that their child is going through troubled times. So now, because of the experiences we've had, I always advise them to go back to their families, to somebody whom the child listens to or respects, and sort of ask them to to explain the situation to them. So the families play a very important role, because they can come together, give support to the family and the child or whoever's going through that troubled time.
Thank you.
Thank you. Thank you.
We have two cancellations. Dr. Pat had to go back to Australia, and Mahesh, I think, will talk to us later. We only have one presentation left before tea. It's been delayed. Dr. Rishabh Koirala from Nepal, please.
Good afternoon, everyone. I'll try to make it short because it's been quite a while and we're getting delayed. I'll be talking about the mental health scenario in Nepal with the little bit of data we have from research, as well as my personal experience while working in ground level, as well as I gained some experience while working as a focal person for WHO. So that will be the overview. These are the points. So to start with statistics, there are a total of 157 registered psychiatrists, among which 130 are currently working, 1 de-addiction specialist, 2 child psychiatrists, 1 more in making. They are having their training in the Nimh, and there are 28 clinical psychologists. I wanted to specify this because we have probably hundreds of psychologists, but they don't have any clinical experience, but they are doing some work. We must admire that work, but they are not trained in clinical psychology. Psychiatric nursing, around 62, but almost none of them, only few, very few, are working in psychiatric wards or related fields related to mental health. because they just do their degree and work in other sections. There are no occupational therapists, so psychiatry social science, it just started 2 years back, and there are social workers working in the field of mental health, but they are not trained in the field, trained specifically in mental health. So with this ratio, we can say that we have 0.4 psychiatrists for 100,000 people and 0.1 clinical psychologists for 100,000 people. There's no national epidemiological studies, but one has been currently started with the help of government of Nepal and Nepal Health Research Council. Very few small-scale studies, and the prevalence does not appear to be different from what has been shown by global studies, and no studies on treatment gap. Another important point that I want to make is suicide has been seen as in a decade ago research done by WHO along with collaboration with government. Suicide was seen as the main cause of death in female of reproductive age group, but still after the report no actions has been taken. The very few hospitals which is providing psychiatric services, several major cities in Nepal do not have a full-time psychiatrist. What most of the psychiatrists do is they run satellite clinics. They go there every month, see quite a bit of hundreds of patients in a day or two. But I must say even that much of service provided by those psychiatrists privately is also good for those people who could not have services at all. And currently undergrad, now to talk about a bit about academic and mental health education in academics. There are 3 major universities giving degree for MBBS, and 2 of them have psychiatry as a compulsory course, whereas one which has the biggest number of medical colleges affiliated to it does not have psychiatry as a compulsory thing, because it comes under internal medicine. So a student would not study for the total 5 marks of that internal medicine portion, a whole subject. So they would rather skip it and devote their time to study internal medicine to get a better ranking or better score. So that's also a big problem. Postgraduate training has been provided by 9 institutions, and the sad thing is, even I got trained in one of the good institutions in Nepal, but psychotherapy is not a part of curriculum for MD psychiatry training. So it's a big thing, and that needs to be changed. Another important thing that I think, which is really important, is inclusion of anthropology and social sciences in the MD curriculum, which is also not there. Another, the patients, due to stigma, they would rather, patients suffering from mental illness or mental health issues, they would rather go to a neurologist or neurosurgeon in Nepal. Usually they go to neurologist or neurosurgeon at first. So, but the thing is, in neurology, they don't have any content on mental health or psychiatry. So that also creates a problem. As I mentioned, Masters in Mental Health Social Science has currently been started, and DM in Child Psychiatry is been planned with collaboration with Nimh, I think so. And there are plans to start PhD in psychiatry in collaboration with University of Oslo. Then it's running now. It has already been started. Now, another important thing about mental health in Nepal is that it was even a taboo to talk about mental health in Nepal few years back. But after the earthquake happened, most of the people suffered from some form of mental health issue. So then a huge realization among general population came that yes, a normal person can also have mental health issues, and it's not a big deal. A person need not have a very hard mental illness or psychosis to be suffering from mental illness. So in that way, the earthquake became a boon for the upliftment of mental health in Nepal. And the government saw it as a need because the donor agencies who were supporting the earthquake victims said that they need to address mental health issue alongside physical and other issues. So WHO created a post. That was a very big step. There was an increase in budget by Health Ministry, and several programs was started after the earthquake. So I'll just give you an example. This is a scene from very rural area in Nepal, a very rural area. They have this instrument that's made in a big log, and that's called thedko. And people, when they have psychosis, and when these patients, they are taken to faith healers at first, and then paramedics, whoever is like available in that rural area, and when no treatment is found, family members, they lock their leg in this kind of big log so that they don't run away or they don't harm themselves. This guy, he had been locked in this log for 18 years when I first met him. And he showed dramatic improvement with risperidone. But what I want to emphasize is people are still not aware about the existence of mental illness. And even if they know about mental illness, they see it in a different form. They link it with spirits, ghosts, and other things. So currently, quite a bit of steps have been taken. Recently, very recently, around 4 months back, government established a mental health desk in Health Ministry, which is a big step because policies could be forwarded, and several steps can be taken after that. We currently, around 3 months back, we received a NORPRAD grant to revise the education system and mental health education system, even revise curriculum, because the undergrad curriculum as well as graduate curriculum, postgrad curriculum for mental health, that has been the same for 15 years. Since the beginning, it has not been revised. So a lot of conferences has been organized nowadays. That has its own value because it increases awareness among people also. And the participant, around 3 years back, till 3 years back, all the mental health conferences were only targeting psychiatrists. So it was only limited among psychiatrists. But nowadays, we have been open to everyone, even service user, everyone related to mental health. That has really increased awareness. We've been inviting ministers and people who reform policy. That's why that's been a big help. Other important developments, we've been working on translation of words like depression, anxiety. We didn't have any words for that, depression and anxiety in local terms. And that was another big issue because we had difficulty explaining patients. We have difficulty in making brochures or writing books in our own language. So that has also been started. And a work on telepsychiatry has also been started. The government increased the free drug list, number of drugs in psychopharmacology from 5 to 10 because we only had chlorpromazine and amitriptyline 25 mg as free drugs, which was really difficult for us to use. And apart from that, there are other things that's been going on, like methadone maintenance program. Buprenorphine has also been added recently. TMS has been started in a private center. And what I want to mention is, like, without addressing or including the culture of our country, I don't think mental health cannot be addressed like as a whole. So a lot of research has been conducted. There has been a lot of studies on shamans, how they have been addressing mental health issues from long ago and how they can be included in the treatment of mental health, like training these shamans about mental illness, how they should refer the severely mentally ill patient to specific places and so on. So MSGAP has been a very important step in the development of mental health. Government has government is still running MSGAP program after the earthquake, and even a few weeks ago, I was also giving trainings on TOTS. I was running TOTS on MSGAP, and this has been continued. And there are several villages, rural villages, where MSGAP training has been done. And that guy, like the photo I had shown earlier, even in that area, that guy could get help because of MSGAP training. So I just want to end my presentation with few things that I think should also be thought about when we think about mental illness in our area, underdeveloped areas, part of the world. Mental health issues, when we address mental health issues or when we talk about mental illness, we are always seeing in the Western point of view. I think there should come a change about that thought. Like we should, yes, ICD-10, DSM-5, they really guide us, but I personally think that there's more to that. When we talk about mental illness, we have to see things like, for example, I won't go in detail, but like conversion disorder has been seen as a part of life of so many people in rural areas where they take it as a form of livelihood. And how much should we medicalize mental illness? ADHD, there was no ADHD when I was a kid or when I was even in my 20s. So no one got treated for that, but things were managed by family and society. I think those things should also be emphasized rather than giving medicine for, like, if needed. Even I give medicine to kids who have ADHD, who are out of control and who need help. But other modalities that have been used till now, that should also be taken in consideration. So, as mentioned earlier, there are lots of things like everyone talks about resilience in Nepal after earthquake. They say that the mental illness that was supposed to be present in the general population was not seen in that number. So what could be the cause? A lot of studies could be done. And as mentioned earlier, utilizing traditional healers and use of our old social system should also be emphasized. With this, I end my presentation.
Thank you very much. Questions? One or two brief questions? Please. There's a mic coming to you.
Thank you very much for a nice presentation. Just wanted to kind of make comments and also question that you talk about translating Western model into local terminology with cultural embedding.
Yeah.
In Pali literature, which is Pali literature is Nepalese, that region, Nepal and northern UP. There are descriptions of numerous mental health conditions, right from mania to anxiety to depression to
delirium
and everything. And so those words exist, but I think sometimes the problem is that we get too pedantic about definitions, and rather than looking for a pre-existing local cultural linguistic tropes which actually work for people. But the problem with any kind of establishment is that they want to impose rather than relate. I think that's one. And in terms of the medicalization of mental illness and the Western medicine, I think we talk about these. We've been talking about this in a very generic way for a very long time. Although the differentiation between Eurocentric model of psychology and psychoanalysis was highlighted in 1920s, but we haven't done a lot about it because it's the we've got into that, we've taken the easy way, which is, there's already a developed model which sells. So we just adapt that and start selling it, rather than taking a tougher look and invent our own model of mental health. Because that's the only way. We have to innovate and look at, properly understand where we stand and how our minds work, and develop our own mental health model, and then take few things from whichever culture which are helpful. Thank you.
Thank you. You want to say anything, or you?
You'll just add some comments to that. Yeah, for the translation thing, I'm also directly involved in that. We are open to things like if we don't find it's not that finding a totally Nepali term which no one has ever heard, or it's in like old books, but there are few terms we can, like for example, for bipolar there were lots of suggestions, but bipolar we didn't find a good word, so we thought like we should go ahead with the term bipolar. But for example, another word, delirium, for delirium we have a term called sannipat, which is very much used, even people in rural areas, and everyone knows. So we think we need to revive those kind of words. So and like depression, whether we call it udasinta ko rog or we call it dukha ko rog, so at least we should come to a consensus. That's my point of view, and that's what we are trying.
Okay, thank you for this final important comment. We should all thank all speakers for giving us an excellent session, starting with the application of GM hat in a variety of settings, and of course learning about several models of service. They're all excellent, and of course learning about Nepal. But last but not least, of course, the person who shared her family experience of someone, a child with mental health problems. We are very grateful. Thank you very much.
Thank you, all the panelists, for your valuable insight. Now we will proceed for the tea outside and will resume here sharp after 15 minutes for our next session. Thank you.
साइड बताइए किस पे डालना है डाल दें। अच्छा तो मैं सेट करके के लिए गेप रख लेता हूँ आप डिस्टर्ब इसीलिए डिस्टर्ब को ऑटोमेटिक ले जाएगा मेरा आगे रखो फिर आप आगे जाओ इधर आने के बाद पब्लिक भी डिस्टर्ब है क्या पोजीशन है ऊपर ही आओ, इधर से रास्ता है ना। इस लेग को छोटी वाली ऊपर करो, वो इधर आ जाएगा तो टलना नहीं लगेगा। मैंने ऑन कर दिया, बोला करो नया,
नहीं बोला क्या नहीं, मैं तो अपनी
अच्छा शाल पर क्या डालूँ तो इसमें
आप नीचे कैसे आए?
दोनों फोटो भी चाहिए।
अच्छा,
तो फिर वहाँ से आने में भगने में दिक्कत आती है, तो ये भाई साहब दोनों संभाल लेंगे कैमरा।
5:30 में जाओगे ना, क्योंकि उनका ही जाएगी,
अच्छा कब
अभी है इसके बाद
उन्हीं का था,
कई उनके सेशन कम हो गए।
हाँ
जो थे ना चेंज हो गए।
अब ठीक रहेगा यार, इसको ऊपर कर दो। मैं गैदरिंग मिलूंगा, मैं तो उधर मेरा फिक्स रहेगा इधर। चलो देखो जी सीधा कस लूँ, एक मिनट इधर ना कर सही।
मैंने यहीं लगा दो, अभी आप फोटो खींच लो, फिर उसके बाद फिर चेंज कर देना, यूट्यूब में डायरेक्ट आप लगा देना कि आप कर देना वो, है ना। आओ मैं टॉयलेट लेके आता हूँ।
ऑडियो ब्लैक इसमें तो हाँ होना
हो जाएगी ना ऑडियो तैयारी
हाँ लग जाएगा नहीं HDMI में ऑडियो नहीं आती
नहीं आइए मेरे को तो आएगी आप इनपुट लोगे तभी तो आएगी मतलब आपको ऑडियो की इनपुट दे रहा हूँ मिक्सर से होगा
नहीं वो तो
हाँ हाँ
आप HDMI आउट लोगे
हाँ
उसमें ऑडियो नहीं
आ
जाएगी
जाएगी आ जाएगी ना मेरे पास
अच्छा वो आपको वो मिक्स वाले आएगी
ये अपन ये वाले देखिए
कोई दिक्कत नहीं
कर लो अपने
करो लगाओ आपके वायर में
बैटरी करवाएंगे फ्री हूँ आप भी फ्री पहले ऑडियो निकालेंगे ऑडियो की सेटिंग कर लो पहले कैमरा क्या लाइन पे चल रहा है कितना नंबर 1 नंबर लगा ना चेक बोलो उनसे कुछ
एक और देखो इसको यहाँ से बंद करते हैं
I was actually expecting a panel.
Yeah.
This has become like presentation, so I've just succumbed to the. I was thinking there'll be a moderator.
इनपुट 1 पर डालो आ रही भी ऑडियो आ रही है
Well, that was the idea, but
हम वो कर लेंगे इसमें
because people take a
वो
lot
सब
of
इसको बंद कर देना तो पहले
You say that
इनको वैसे है
3 minutes, say
ये वैसे चेक
a few
करते हैं
messages, and then let us
नहीं
discuss
सबने नहीं
these
सब पता रहेगा ना
right
भाई
now,
वो ऑडियो बंद हो
what
चुकी
the
है
issues are, and then people can start interacting. But it's never easy.
लगा रखी है ना उन्होंने एक तो लगा रखी है को लगानी है एक किसी को बोली नहीं मैं चेंज करेगी
अभी देखो बंद हो गया ना
अच्छा हाँ आपका
नहीं समझ
अब लेवल की
अब चेक करो अब आगे देखो लगाते इसका मतलब परफेक्ट
चलो वो तो चेक कर लूँगा मैं
हाँ
केवल चेंज HD पहले वीडियो आउट में आऊँ आपकी बार आपके कैमरे में वीडियो आउट में आऊँ
Lena kept on telling me one time, and how to happen to these phases, but one was the visa issue we couldn't do the last time, visa, and so we passport to the and then I got the chance.
Complex.
Yeah, well, that problem was taking talking about people
ऑडियो भी बुलाता हूँ मैं अब इसको बनाऊँ
Oh, this is your first training. Yeah.
the China prize, Japan prize, Thailand, Singapore, I'll come back.
Oh, you need it.
Tomorrow. In here for 10 days, I was with Dima.
You went to the Ancestors. That's another.
And the Dima said himself, he's not like that. It's not like this place. And then we actually took a day off.
Conference will next January. Yeah.
Take this one.
You are being second account.
Yes, I am.
I'm chairman. Professor Gupta is there.
Okay.
So what I was telling you that because
You can just keep running.
I'm going to be very tight on time.
Sure. How
10
much time?
minutes. 10 minutes.
Oh, more than.
Oh, brilliant. Brilliant. That will be even better. You'll get a chocolate from me if you do that.
Let me try.
Okay.
5 to 8.
Ah, best. Super.
Chocolate if I finish before 8.
Before, yeah, okay.
What kind of chocolate?
That you can ask.
Ma'am is there, so you invite. Start. Chair is already sitting. So Dr. Manoj and Dr. Ma'am, so both are there.
Gultan ji, बाहर से सभी को तक अंदर आने के लिए आप शुरू करो खाना पीना लेके आने के लिए बोलिए
A very warm good afternoon to all present. This session is on public involvement in mental health. For this session, we have an esteemed panel of Dr. Mahesh Odyur, consultant psychiatrist, NHS Foundation Trust UK, Dr. Manoj Kumar, consultant psychiatrist working in London. His interest areas are media and filmmaking. Dr. Prabha S. Chandra, professor and head of psychiatry, Nimh, Bangalore. I request the panel of esteemed dignitaries to take their seat on the dais.
This is just the three of us. Let us sit close by.
This session will be chaired by Dr. Mahesh Odyur. Dr. Mahesh Odyur is a consultant psychiatrist, psychiatry of intellectual disabilities and strategic clinical disorder, NHS Foundation Trust UK. I now request the chair to proceed the session.
Thank you very much. Well, I was supposed to do the talk last time. I was stepped down from that due to time constraints. But instead of that, I was uplifted to become the chair of this session, which I'm really glad to invite our two panelists. Mrs. Garg did her speech, did a talk earlier on. So, and also because we are really short on time, I've spoken to the panelists. I said I'll be very tight on time, and I'll give them a warning after 5 minutes, and we'll finish in 10 minutes each speaker. That's what we are going to do, with permission from the panelists.
Absolutely fine, and thank you.
Okay, there you go. And if you are left wanting more, then blame me, not them. Okay, right. On that note, can I invite Dr. Manoj Kumar to talk to us about media and mental illness?
Well, thank you very much. My original presentation, usual presentation, is 45 minutes, and another one is hour and a half with clips and etc. So today I've been freed from that, and I feel really thankful. So in terms of media and mental illness, I think all of us are already aware that how media has portrayed mental illness, psychiatrists, and mental health professionals in various forums, whether it be cinema, whether it's the broadcast media or mainstream media, and then there is this whole mixed and very complicated picture emerging in social media. And within social media, now there are, I think, nearly 1 billion school of thoughts. And each school of thoughts is equally valid sometimes as far as they think. So the challenge, I think, today is not just how mental illness and mental health is portrayed, because there are lots of good apples as well. So it's not all bad. And a lot of good work is happening, a lot of awareness is happening, and but it's a spectrum. And I think the challenge today is not just whether we are being talked about or the mental health is being talked about, is how it's being talked about, what's the quality of it, and where, how to separate quality from all kind of misinterpretations and misinformations. And I think that's where our challenge lies. And the role of mental health professional over the years, what I've learned is that we are not trained to interact with media. And I think in Western countries, they have developed this awareness. So now there is training and there are workshops. But from time to time, particularly say in the context of community psychiatry in India, I've come on television, etc., spoken about it. I've seen other people. I thought I was great and I was doing the good service. But when I looked at the actual video, I realized that I could have done this better. I could have done that better. Oh my God, this is horrible. How could I say that? Why did I blurt that out? And because from the broadcaster's perspective, that was the most dramatic moment. So she kept that in. And I asked her, I said, why did you keep her in? She said, I thought that was hilarious. That was really nice. And that made me realize that how the articulation of mental health happens. It has to be thought about very seriously because it has huge impact, particularly when it's broadcast media, when it's the mainstream media. And I think what we communicate through the mainstream medium, it's then gets translated or interpreted multiple times. If the original text or original presentation, original articulation is not accurate, simple, and accessible, then it opens itself up to multiple misrepresentations. And I think the importance of it not only lies in spreading kind of misinformation, but also it has impact on the policymakers, the influencers, and people who actually fund mental health, people who actually provide support to mental health. So there are kind of huge number of implications. And personally, I feel that from a mental health, articulation of mental health needs and services, it should be thought of clearly and as precisely as possible. Just like, Vimal has mentioned about, the MD had, that it's not a rigid science. It's not something you slap a patient with. It's something you invite the patient in with. And I think that kind of, that interaction between and mental illness is vital. And I think as we are developing mental health services, we need to also really think that how we're going to interact with media and what kind of information we are going to kind of put on social platforms, and also play the role of first clarifying it for ourselves and then clarifying it for the community, that this is one portal, this is one place where you can look for authentic information. This is what mental health is about, and also point out that, help them to separate misinformation from information, from more kind of useful information. And I think in 5 minutes' time, roughly that's the point I would like to make. That as mental health professionals, we need to become not increasingly aware. I think we need to be acutely aware, because now we consume as much media as much, as we consume oxygen. So it's almost like we breathe in and out media 24/7. So it's very essential part of any kind of mental health work and mental health promotion. I think I would like to conclude the summary of my presentation here. If there are any questions, you can ask me.
Can I, as a chair, I wish we have more panelists like this. I did not even need to give you a time warning. That was excellent. Thank you very much. On that, I think there will be plenty of questions, and I wanted this to be an interactive session where we probably have more time for questions rather than people standing and asking, saying things. Is there any questions that people want to ask about media and the impact? Yeah.
In India, as we are aware, I'm not telling something new, but media has a very vital role to play. The films which had a very positive impact about disability, immediately striking to my mind, there was a film Black, where deaf, blind, impairment was very positively shown. Other film was Koshish, where speech and hearing was shown in a very positive way. And also recently, Amir Khan's Tare Zameen Pe. But why? Why mental illness? Society somewhere, they are feeling that mentally ill means gone case. So we have to lobby in the media also, why you portray negative things. Like all disabled people are shown as a villain, not as a hero. So,
I think this fight between media and because madness is attractive for broadcasters, filmmakers. So they look for drama. They're not looking to promote mental health. First of all, we have to understand we are coming from two different intentional perspectives. I think we have to align ourselves. We have to find ourselves informed and then find right articulation for it and then engage with media, not fight with media. You cannot win. You just cannot win. So you can simply collaborate. So you find yourself a place on the table where you can communicate. So you find friendships, you find collaborations, whether it's making a film, filmmakers or documentary filmmakers, mainstream media, broadcast media, if there is a seed. But problem is that a lot of us do it for a purpose that we feel it's driven from a very narcissistic perspective. Oh, I'm on TV. And then we forget. I've done that so I can talk from experience. The first time I did it, I thought, oh, wow, that's something very special. And when I looked at the clip, it was embarrassing for me. For them, it was great. So, and I questioned myself that why did I go? Was I trying to promote mental health or was I just trying to promote myself? And I realized that I was trying to promote myself, but I taught myself otherwise. And that skews the picture because your articulation becomes different since your intention is different. So I think that awareness of, that intentional communication where the communication is for a purpose, for promotion of mental health, from promotion of or highlighting or the plight of mentally ill people and the deprivation and the gap in services, etc. For that, I think we're very sincere and very, at the same time, a very proactive dialogue is needed. So you have to make friends with media, but at the same time, not get carried away by them because it's a very seductive place where within 5 minutes your Twitter handle is, going mad once you appear on TV, and in the newspapers or articles when we write, sometimes there are a couple of psychiatrists who write columns, and I find inconsistencies, how they are kind of portraying or taking a very non-committal stance. So I think, as you said, the media is vital, but it's equally vital that we kind of analyze our position and our actions and our interactions, and then make friends with media, and then utilize that platform to promote mental health.
One more question at the back.
Sir, first of all, I would like to thank Sir for asking the question on how we can involve the media for destigmatizing mental health. My question has got two parts. The first is a comment and the second one a question. Now, when we get influenced, we don't get influenced by the national level influencers or the international level influencers. I will take an example of Kalpana Chawla. She was an ex-Indian astronaut, and many girls don't get inspired by Kalpana Chawla, but by someone who is near to her home, whom she can relate to, who comes from the similar circumstances. Now, social media is a great platform for destigmatizing mental illness because it has got reach and it has got power. Are there funding agencies which are willing to fund social media-based influencer initiatives to destigmatize mental illness by taking interviews of the local influencers in the community? And if yes, where are they and how can we approach them?
I think that's a wonderful comment on what actually works. So people will listen to you when they feel listened, and they feel listened by people who they can relate to more often. And that's why Three Idiots gets 1 billion people talking about how should children be educated, because through the talent of acting or the context, they relate to the context and then they start questioning. So I think that relatedness is really crucial. So we can't expect somebody in a rural village of, say, Jaipur, to be influenced by Madonna when Madonna is telling them, look, mental health is important and you should take your medication. We can't. Because there is no, even if you're in awe of something, that doesn't mean you're going to follow. And I don't know about funding places, because I think Vimal will probably be able to help, or maybe Abu will be able to help. But I think a lot of people are trying, and if we look for it, we always find funding sooner or later. But the important thing is that how do we identify local influencers? And if social media groups have the power to trigger riots and get 45 people killed on a false rumor, then I'm sure it has the power to change things positively in mental health as well. It's just that, how we create those circles of influences locally, and WhatsApp groups, they are great influencers. And politically, within these groups of 500 people, I see that how this whole debate about right-wing politics and left-wing politics goes on. That debate itself generates lots of ideas, and then there are influencers within those groups who then influence a whole pack of people, like 200 people almost kind of converted. One video can convert people. I'm not saying that positive things go as fast. It's easier to spread negativity than positivity. But the local influences are very important. I think it's a very important theme in kind of media and mental illness interaction.
So, can I, on that note, can I move us on to the next talk? Thank you very much, Dr. Kumar. That was really, really inspiring talk. Thank you. So, can I now introduce you to Professor Chandra. I had the honor of meeting her just earlier during lunch. And I have been promised that this talk also will be very short and sweet, but I think it will be on a very, very important topic of women and mental health, which probably is the most important topic, because if we get that right, hopefully we get everything else right. So over to you.
Thank you, Manoj. So, not Manoj, Mahesh. Manoj was the person who spoke before. So I'd like to thank Professor Bimal Sharma for inviting me, and Professor Nutan Gupta. It's been a wonderful day so far, and seeing everybody alert and asking intelligent questions at the end of the day shows the success of a program. So thank you very much. We all know that, sex and gender are different. Sex is the biological part of one's being, and gender is the socialized roles that we come with. And I think gender has a great influence on mental health in many ways. I'll start with a small story so that I show you how gender has been quite neglected till recently in research, in mental health at least. So I had a patient who I prescribed, a young woman around 35 who came to me. I prescribed a medication to her. Her brother was also coming to me for a similar condition, and I had prescribed the same medication to her brother. And she asked me, I'm a woman and he's a man, and you prescribe the same medication in the same dose. Does it really make a difference? Do I metabolize the drug differently from him? Would you be able to give me answers? And that's when I started, this happened a few years ago, and that's when I started looking at the literature on sex and gender and its relationship to many mental health problems, particularly drug responses, and was dismayed to find that you really didn't have sex and gender disaggregated data on a lot of variables. That most trials did not report sex, women and men's data separately. It was also when I kept going back in this literature, and I found that even the cell lines that are used at the basic level of forming, getting a drug made, are usually male cell lines, because it's easier to handle male cell lines. It's more expensive to have female cell lines in research. The animal models on which medications are tested are also male animals, male rats, because female rats have an estrous cycle, and to sort of control for all the changes which happen in an estrous cycle for a male rat for a female rat becomes more expensive. So as a result, what has happened over the years is that a lot of data on interventions, on medications, which come to us and which we use has really not been tested out in women adequately. And that's when something called the SAGER guidelines came up, which is basically the editors of all the major journals of the world said that they want sex and gender reporting guidelines, and that every article should actually mention if sex and gender was considered. If it was not considered, then what was the reason, and analyze data which was separate. This is just to give you an example about the kind of sensitivity which needs to be there when we talk about women and mental health, and the fact that, and this is just about women, and we have not considered the different life stages of a woman. So we know that any intervention has to take into account, let's say menarche, it has to take into account the perinatal period, which now we know extends from pregnancy till 1 year after childbirth, the menopausal transition. So I think that when we're talking about women and mental health, we're talking about the social roles which impact a woman's mental health, and we're also talking about the whole range of biological variations in a woman's life. So I think it's a complex situation, and I'm going to, that's the major thing that I wanted to talk about. I'm also going to talk a little bit about some of the trials that I have just been involved in, and just give you a glimpse of 2 trials which involve women, are particularly geared towards women and are very gender intentional, and I will describe them very briefly. And finally end with the initiative that Nimh has started, which is not only for women, but women use it a lot, and this is called the Nimh Center for Wellbeing. So just to give you an idea about what is gender intentionality. So if a program is gender unintentional, it really doesn't look at what what is specific. What do you need to do to a woman who's, let's say, self-harming compared to a man? So a gender unintentional program doesn't look at anything through a gendered lens, whereas a gender intentional program looks at things through a gendered lens and then assesses impact based on gender. And also, this is an article from Melinda French Gates, which came in Science, and talking about gender intentional research, and that research needs to be gender intentional. And I think that's something that should drive all of us, and that in some way, any gender-related research that you do should also lead to some amount of enhancement or empowerment of the woman. So this is one very interesting technology which was developed. It's a very, so basically this is something called the iodine dot. In rural India, women were not taking iodine and were suffering from thyroid disorders and iodine deficiency. And however much the physicians told them to take iodine, they were not taking it. So somebody came up with this really creative, very gender, friendly idea that you soak the bindi in iodine, and that is something that all women will use. If a woman keeps it for about 4 hours, she gets her daily quota of iodine. So it's just such a simple intervention which got an award actually, but it takes into account what women may want, what women may like, and what will work for women. So these are some of this is a simple example of a gender intentional kind of an intervention that will work. I'm just going to briefly take you through a couple of trials that we've just finished. So this is in Karnataka, there is a place called Belgaum, which is like right on the north of Karnataka. So Bangalore is somewhere here, and this is Belgaum. It's about 400 kilometers. Now, Belgaum is a place where HIV prevalence was very high, and we had reports of women with high rates of depression and suicidality because of HIV infection. So we did a trial, which was a randomized control trial, supported by the NIH with Yale University, where what we did was, and there are very few, there's not enough mental health expertise in Belgaum, and those who were interested in HIV and women were even less so. So one of the interventions we developed was using mHealth so mobile phone health by nurses to improve the quality of life and healthcare and decrease depression. So these were women who were attending the ART center in Belgaum. And these were basic nurses. So they're not psychiatric nurses. These were 3 basic nurses who had just not even done a BSc, this just a general nursing, who were trained in offering mobile phone related self-care interventions and mental health assessments and help from Bangalore. So they're sitting in Nimh using mobile phones, helping women in Belgaum. And this was a 2-arm trial. So both groups of women, 60 women in each arm, women with depression or psychosocial vulnerabilities got mobile phones, and through a closed group technology, the control group did not get any intervention. They just had phones. They could call us if they felt like. The intervention group had regular sessions at 4 weeks, 6 weeks, 8 weeks, and 12 weeks. And the outcomes that we used were treatment adherence, depression, and viral loads and CD4 counts. And what was very interesting in this, this study was funded by, like I said, NIH and ICMR. What we found was that it was easy to do, it was feasible, it was extremely acceptable to the women. Like I was discussing about using qualitative research, we actually had recorded all the interactions between the nurses and women, and analyzed about 1,800 phone calls, took out the rich data from 400 calls, and actually analyzed all the data about what women talked. And it was very interesting to see that these women had never met these nurses, but they were completely willing to share extremely personal concerns about stigma, sexuality, disclosure, depression, suicidality. Though we didn't really find much difference in the CD4 counts between the two groups, what we found that the depression scores actually came down and quality of life improved. So this is just, and then this was a by women, for women kind of an approach which was extremely feasible and acceptable. So this is one small intervention which indicates that this technology and this method of intervention can actually be used for other conditions as well. Let me go on to another brief intervention, a trial. And so this is a trial which we've just completed. It's called Intervention for Mothers in Pregnancy to Reduce Exposure to Secondhand Smoke, the IMPRESS study. And we've just analyzed our results. Now, when we were going to women in the perinatal clinics, in the antenatal clinics, and talking to them, one area which was bothering them a lot was their husband smoking at home when they were pregnant. Our antenatal cards don't ask about exposure to secondhand smoke routinely. And so when we were assessing women's mental health, one of the reasons they said was that we are very worried about the fetus because laws in India now prohibit men from smoking outside. So they're all smoking inside the home, and these are tiny homes. And we are worried about our fetal health as well as the health of the newborns once they're born, because there are lots of respiratory conditions. And so this was a trial which we did, and we learned everything from the women. So the intervention was actually developed using qualitative information from the women, from the grandmothers and the men. And to just give you a brief idea about the intervention, this was a multi-component intervention. We had a picture booklet with key messages through graphics, and it was as if the baby was sort of talking to the couple. There was simple, again using a little bit of technology. In the antenatal clinic, in 5 minutes, we could actually use a strip which looked at the woman's saliva cotinine. The cotinine is basically a nicotine derivative which shows the level of nicotine in a woman's body. So we could, in the antenatal clinic, in 5 minutes, we would do a saliva test and give the report to her and say, take it to your husband and show it to him. Show him how much cotinine you have in your body. And we had a letter from the future child to the father, which basically said, I want clean air, and when you smoke, I can't breathe. So very, very, interesting letter. And then we had regular automated voice messages to the husbands at periodic, intervals. After 3 months of the intervention, we did the intervention in about 14 weeks. 3 months after the intervention, we went to the homes of the mothers, again did the saliva cotinine. The intervention group had a significant drop in the saliva cotinine compared to the control group, which just got a leaflet. So here we actually intervened in men using a very gendered kind of an approach through the women, then sort of enhancing the family well-being by intervening through in both groups, but taking into fact that pregnancy is a time where most mothers and fathers will make a change for the improvement of health of the fetus. So these are some examples of work that we are doing. I'll be happy to answer questions. Finally, just to talk a little bit about this center, which is called the Nimh Center for Wellbeing. It's about 3 kilometers east from Nimh. It's a center which is away from the main hospital. It is very friendly. It is very welcoming. We call it the youth-friendly center where people can drop in. Most of the people who come in here drop in with relationship problems, stress related to exams, the kind of mild mental health problems that we've all been talking about. And it's a unique center because it is run mainly by a nurse and a counselor, and mental health professionals, trained mental health professionals, only visit if necessary and only for specific purposes. So these are some of the, and this is extremely popular with women in the neighborhood because they can just walk into the center. It's not stigmatizing. They get a cup of coffee. They get to chat with the nurse, have women's groups. So I think these are some of the kinds of innovations and interventions that can be done, which are more gender friendly and which take into account the, the social realities of women with mental health issues. Thank you very much.
That was absolutely inspiring. Now, any questions? Okay. I like the iodine dot. Very interesting.
Yeah, thanking both the speakers on media and as well as women and this mental health. I would like to ask something to ma'am. Considering both the speakers, what they have said with regard to media and what is being done over here, you have used the mHealth, this intervention in this Belgaum project. So over there, do you consider that had it been possible that the clients who were depressed and who were speaking with the nurse, if it was that a social network of those clients was curated after the end of it, or it can be in future, and that can be mediated to have a mediation from the nurse or somebody from behind, it can be mediated. The exchange of views amongst them will be very helpful, beneficial for them, considering that a person who has already suffered is sharing how they have been coping with a particular disease as such. Do you find that?
Yeah, absolutely. I mean, I think that is another form of intervention. And we all know that the social capital and social networks are probably the most protective for any mental health issue, and particularly preventive for depression. So that's another form of intervention. A lot of the women in this trial prefer to talk to us in privacy because disclosure has always been a big issue. They don't mind groups when they go to the ART center where they get their medication, but in the community they don't want to be identified as being positive. So it's possibly possible in a hospital environment or a clinic environment, but might be very difficult outside of that when these women are kind of dispersed in various areas. So, but it's a very valuable form of an intervention, any group intervention.
Okay, on that note and on the basis of time, can I bring this session to a close and we can go into the next session? Would that be okay? Thank you very much. UK, which probably is as much as challenges as has been described here. So I won't go into details because it will be repeating the same things that people have repeated all through the day. And this is the cost, which again is something that we have discussed all through the day. So interestingly, this was the priority set by NHS in the NHS 10-year plan, and if you look at the priorities, it is no different from all the priorities that we are saying, which is right care at the right time and of right quality, an integrated approach to physical health, mental health, and promoting good mental health and preventing poor mental health. Probably all the things that we shared today. So again, I wouldn't have said anything different in my previous talk. So I just thought I'll send a little blurb for my organization. And I definitely did not pay them to put my picture over there. And that statement, what matters to people and not what is the matter with the people, I think that is the absolute key, and that is the absolute, if there is one message if we can take from this whole meeting and whole conference, I think that is that. So, this is, I had slightly worked on this presentation. I think it's the other one. There is one more there, up, that one. Might be that one. Going down. Yeah. No, going down. There. Yeah. So you can see I had put thank you as well for the previous one and moved on to the next one. So anyway, so this is my current talk on learning disabilities and the challenges. So I just put the challenges as a first point. And they're all the challenges. Support for families, choice in accommodation, access to mainstream health services, access to specialist services, transition and challenges there, crisis support, good hospital care, and most importantly, good and meaningful life. Now, it's interesting that when I showed the previous one, which was on mental health, it did not have this richness. And when I talk about learning disability, it has all this richness. But it is the same for mental health, just as important it is for somebody with learning disability and other issues as well. Because why should we leave out support for families for somebody with mental illness? Why should we not ask for a good and meaningful life for somebody with mental illness as well? So probably we in intellectual disability have moved on a little bit more and thinking a bit more broadly as well. It might be. But these are the challenges. What can we do? And this is, I'm saying challenges in UK, but I think this is the same challenges here as well. What do we have over there is we have certain things. Learning disability psychiatry and learning disability services have evolved a little bit more in UK compared to some other areas. We have primary care services, we have secondary care services, and we have hospital services, especially catering for people with learning disability. But even then, it just scratches the surface. It doesn't meet all the needs of all the people who need care. And when we have all that and we are just scratching the surface, when we have none of those, I don't know what we do. And this is the question that I've been asking people, during my last 3 days, this exact thing that I've been asking everybody as what do we do with children, families, people with learning disability? What support can we offer? What support is there available at the moment? And the answer is nothing. There are bits and bobs. There are, some islands of good practices here and there, but nothing that links all those sort of things. So I've been trying to see whether I can, piggyback on some of the existing, conversations that are going on, the Sashi project and other things, to see can we at least identify some of the areas and some of the areas of good practice and try and do something different. So these have been some of my conversations during the last few days. What are we trying to do about this in the UK? A document called Transforming Care and Building the Right Support was developed about 3-4 years ago. That's on the basis that we still felt that the services that we have is significantly inadequate. People were spending a lot of time in specialist hospitals. People were left over there for years and years. And there was an incident in a place called Winterbourne View Hospital about in 2012. There was a program in Panorama where one of the members had taken a secret camera to the hospital and filmed what was happening. And the amount of abuse that was going on was horrendous. People were being beaten, people were being abused, people were being held down. It was horrible. And on that basis, government made a pledge that they want to close down hospitals or the specialist hospitals for people with learning disability, and right support will be offered out in the community. And sometimes the rhetoric has gone complete the wrong way, that all hospitals are bad. From some hospitals are bad to all hospitals are bad, and all services in the community need to happen, which is good, which is the right thing. But again, it has moved from that position of the hospitals being bad without all the necessary infrastructure being developed out in the community. We have been trying to do some things about that. This is an overview of some of the challenges that I said and the things that people felt would be useful to have as good practices. Now, I'm not going to go through all of that, and I'm pretty sure we can give the slides through and people can have a look. But it talks about some of the good things that we can do out in the community, which by doing that, we automatically minimize the need for hospitals. So we don't need to close down hospitals. If we do them right this way, we may not need people going into hospitals. This is what we did in our area. So we involved service users, carers, families. We have what's known as a Transforming Care Partnership Board, which is just as much a collaborative approach of professionals as much as families and carers. And this is how we outlined what the vision should be for our services, what are the priorities, and how do we develop them together. And that's an ongoing process, ongoing project. This has been going on for the last 3 years, and we are building on things one step at a time. The other big area is autism, and again I have been having some conversation with people about autism, other neurodevelopmental disorders, what happens, and again the answer is just as bleak as it is with learning disabilities. What we want to achieve over there is people with autism living rewarding lives, fulfilling lives, just as other people who do not have autism. And we have been trying to, the transforming care process takes into account not just intellectual disability, it also involves children and adults with autism and other neurodevelopmental disorders. So again, I won't go into a lot of details, but it was the same sort of principles that I mentioned earlier applies to people with autism as well. And that's where I end. Now, I know this photograph is very dear to me. I took this photograph a number of years ago, and Professor Sharma will know where this is because it is not very far away from his house. And I love this photograph because you can interpret it in whatever way you want. I interpret it in my own way, which is there's a young person. That's a statue of Anthony Gormley. Who is a artist who cast his own body in metal, and there are a number of those in that beach, and looking at the horizon, hoping for a better future. And that's where I will end, and I'll take some questions. Thank you, Dr. Mahesh. Questions, please? Any questions? Either I have confused you completely, or I have stunned you into silence, whichever way. I think that's very good. So,
okay.
Thank you very much.
Thank you very much. Now I request Professor Chaturvedi to talk on hidden mental illness in medically ill people.
Thank you, Dr. Babu. I'd like to thank my boss and guru, Professor Vimal Sharma, and Nutanji for getting us here and talking about hidden mental illness in medical illnesses. It's the age of medical comorbidity, and not only medical comorbidity, but actually medical multimorbidity. There are very few disorders which are pure these days. There are people who have multiple disorders. So much so that one of the issues in Lancet a couple of years back was on syndemic approach to healthcare, where there are people who have multiple morbidities. To give an example of hidden mental morbidity and mental illness and medical illnesses, I'll give you an example of cancer. About 35, 40 years back, there was a survey published in one of the very popular journals on the use of antidepressant in cancer patients. We all know that the prevalence of depression, and I'm talking about moderate or severe depression, in cancer is between 40 to 60%. The survey found that how many cancer patients were actually receiving antidepressants was 1%. Just 1% of cancer patients were actually receiving antidepressants. And then we know that the use of antidepressants in cancer patients is also for pain, is also for sleep or anything. So it was not for depression. So I did another survey about 30 years back to look at whether it has changed. No, I mean, it had changed. It became about 14, 15%, but the prevalence of depression was very high. So when we talk about hidden mental illness and medical disorders, it's the other way around also. Thanks to the use of atypical antipsychotics, some of the non-communicable diseases, metabolic syndromes and diabetes-like syndromes, stroke, is actually increasing in patients who receive such atypical antipsychotics. So the non-communicable diseases in psychiatric disorders is high. Of course, the psychiatric disorders in medical illness is high. I've recently concluded an international study of about 14 countries on diabetes and depression. This is called Interpret DDD, and it was headed by Professor Norman Sartorius. We looked at depression in 14 countries, following a uniform protocol. And again, we found that and these were some from Asia, India, Pakistan, Bangladesh, Russia, Italy, some European countries, South American countries, UK. And we found that the rates of depression were actually quite varied. And the overall rate of depression was about 15%, but it ranged from 2% to almost 40%. The important thing was, like in the case of cancer, we looked at actually how many were being seen by psychiatrist or a mental health professional or were receiving treatment. And very few of these were actually receiving any treatment for their underlying depression. So the same thing, now I'm finalizing a paper on anxiety in diabetes mellitus. And surprisingly, we have so much preoccupation with depression and diabetes that I found hardly any studies on anxiety in patients with diabetes. Here also, there is quite a bit of variability, but approximately 10% of patients with diabetes in these 14 countries, which is sample population of about 3,000, have different types of anxiety disorders, not only generalized anxiety, but panic disorder, social anxiety, and others. So we know that the commonest mental illnesses which can be hidden in patients with severity of medical illness from diabetes, hypertension to cancer can be a big prevalence. There's yet another very worrying type of hidden illness, which is something which I studied again in cancer. This is looking at patients who have somatoform disorders in cancer, which means cancer patients who have bodily symptoms which are not because of cancer, but because of mental health problem. Okay? So this is actually of great significance, because most physicians believe that any bodily symptom in a patient with bodily illness is because of bodily disorder. So if a patient with cancer has any bodily symptom, they will think it is because of cancer. But when I did systematic evaluation, we found that actually a lot of them had bodily symptoms like pain, fatigue, tiredness, slowness, difficulty in concentration. And none of these were patients who were actually disease-free from cancer.
but they still had these. For the patient, it appeared as if it is a sign of cancer which is continuing, or a fear of relapse if it might happen. But when you look at it, it is actually a somatoform disorder or an atypical somatoform disorder. Some of them had somatic symptoms because of depression. So what is the significance? This is very, very grave significance, because if a person has pain in cancer, the treatment would be giving oral morphine or analgesics. But if the pain is because of psychological, mental, psychiatric factors or somatoform disorder, it actually does not require more morphine. It requires counseling, it requires low-dose antidepressants, it maybe requires anti-anxiety. So the management is totally different. So that is the third. It is not only hidden, it is an hidden disorder. And unless you look for it, you will not find it. So why is it difficult to find it? And that is because many times when we use diagnostic criteria for diagnosing depression in cancer patients, it's actually very difficult. If you go by the most popular diagnostic criteria of DSM or ICD, we find that most of the symptoms of depression and medical illness are same. If you take a cancer, so there will be loss of weight, loss of appetite, loss of libido, poor concentration, fatigue, tiredness. These are symptoms of cancer, or these are symptoms of depression? These are symptoms of both. These are symptoms of depression, these are symptoms of cancer. So any cancer patient who has this, which they will have, the likelihood of their being diagnosed as depression is very high. So one has to be actually either use a clinical method of making a diagnosis, do not use diagnostic criteria. If you use diagnostic criteria, then you should use what is called as the Endicott's criteria, which is you do symptom substitution. So you don't look at loss of weight and loss of appetite or retardation or any of the physical symptoms as diagnosis of depression, but change them to cognitive and affective symptoms. So that is why it is very difficult to diagnose to measure the severity of depression using the classical scales like Hamilton's or Beck's or PHQ-9. All scales have bodily symptoms of depression. So if they have physical symptoms, depression is likely to be overdiagnosed and it is likely to be measured as severe. There's only one very popular scale, which is the Hospital Anxiety Depression Scale, a 14-item scale, 7 items of anxiety, 7 of depression, and it does not have a physical symptom. It has only cognitive symptoms and affective symptoms. And when we look at what could be the etiology of these hidden illnesses, whether it's anxiety or depression, the commonest is, of course, it's a psychological reaction. And that's what most physicians feel, that it's a psychological reaction to the disorder. But it can also be because of the medications for medical illness. Most antihypertensives cause depression. Most drugs, not most, but many drugs used in treatment of cancer cause psychological side effects. So similarly, there are you take of any medical disorder, you find that it is likely to cause psychological effects. More complex than that is the drug interactions. So drug interactions, if you are going to use antidepressants, anti-anxiety, mood stabilizers in a patient who already is receiving some treatment, there will be likelihood of drug interactions. So the cause can be psychological as a reaction. It can be medical because of the drug interactions, but it could also be unrelated. People who have psychiatric disorder are not immune to medical disorder. People who have medical disorders are not immune to psychiatric disorders. They can have both, isn't it? So it's quite possible. The commonest management should be a combination of medical counseling for the person as well as using low-dose antidepressants. Start low, go slow, and look out for psychological side effects and look for interactions. Usually to detect and manage these for physicians would be either to have a consultation model or referral model, or if it is possible, have a liaison model wherein a person with mental health professional accompanies the management of person who's having a medical illness. In PHCs or in public health systems, is actually very important. It's very interesting that if you have if you train PhD doctors, family physicians in picking up these, they can actually easily do it along with when they are doing an assessment for the medical illness. And we can take the model of the 6th vital sign. How many of you know what is the 6th vital sign? Okay, 5th vital sign. 5th vital sign is the pain. Okay, so it's also coming from cancer. So we assess pain in everyone. 6th vital sign is actually assessing distress in medically ill. So if a person comes with malaria, I'm talking about a common illness to a PHC. So they ask about malaria and the history of fever with chills and rigors, take a blood sample. They can just ask, are they distressed about anything? So same way, if they are seeing a person with hypertension, diabetes, they can just ask, are they distressed about something? One single question. And that will give them a clue that whether it requires further assessment or not. So that should become a part and parcel of all medical practice, that people ask about distress. Distress is perhaps more acceptable than asking about depression. If you ask people, are you depressed? The most probable answer will be no. And as we, or some of the other speakers, there are no appropriate terms for depression. Are you feeling tense? Are you feeling anxious because of the illness? Yeah, some people might say yes, some might not. So distress is something that one should be able to ask. So to conclude, I would like to say that hidden medical illnesses are hidden because of our attitude or because we do not detect them. We do not make efforts to unravel them. But these can be done with an appropriate assessment and with an appropriate management. These can be done. Thank you very much.
Yeah, thank you, Professor Chaturvedi. Any questions, please? Please. Can you pass on the mic? Nice.
Sir, can you say something about the way currently the mental illness is diagnosed? Like, for example, it is based on DSM-5. So, like, still it can be quite subjective. So, like, what would you say about that?
Well, when we are talking about consultation liaison model, or when we are talking about medical illness, mental illness in medical illness, it should be an actual, just a clinical evaluation. DSM-5 is actually not so very subjective. It is based very, very stringent criteria. And I would not say, unless you are doing research or a drug trial or some intervention study, try not to use DSM-4 or 5, whatever, because it makes it really very, it's very good for research, but it's not very good for a clinical practice. For a clinical practice, it's actually a clinical evaluation that would be helpful.
Any more? Thank you. Now I request Dr. Satish on learning and development.
I thank the organizers for calling me for this very, very interesting and meeting in which I must say I learned a lot. In my presentation today on learning and development is on learning and development. So the development of children is a truly amazing process from the time of birth till late adolescence or early adulthood. So especially in the first few years, months of life and first few years of life is truly amazing. And you can see changes in the child almost on a daily basis. So for example, the size of the brain, if you study the volume of the brain, there is threefold increase in the volume of the brain from the time of birth till about 3.5, 4 years of age. So after that, there is hardly any increase in the brain, volume of the brain. So a lot of increase in the, structural maturation, structural development, structural growth, and then functional maturation of the brain to a large extent occurs in the first 3 years of life. So now we all know from morning we have heard that this like all other things, even this development is influenced by a lot of factors. It may be genetic factors or environmental factors, and very often both interacting with each other. It might be either gene-environment interactions or epigenetic interactions. So you have this, which happens from the time of conception, and especially in the early developmental years, and probably later on also. And it's not really surprising that things can go wrong with this highly orderly, orchestrated development of the brain, leading to disruption of the developmental process, leading to limitations in the child's development, and limitations in the child's skills and competencies, leading on to impairments and disabilities. So now the current trend is to classify and to bring together all these developmental problems under one overarching category called the neurodevelopmental disorders. This is the approach in the general scientific community, in the international community, and in the current classification systems, whether you take ICD-11 revision, ICD-11 draft, or the DSM-5. So we have that broad overarching term of neurodevelopmental disorders, under which the classical conditions are the intellectual disability, also called as learning disability in the UK, and in DSM-5 it's called as IDD, intellectual developmental disorder, and in ICD-11 it's called as disorder of intellectual development. So, but in the essence is there is some impairment in the development of intellectual capabilities starting from very early childhood. So that is intellectual disability, is the classical prototypical form of neurodevelopmental disorder, which presents initially in the first few years as global developmental delay in all the developmental milestones. Then you have autism spectrum disorder, and whose diagnosed prevalence is going up and up, and currently kind of stabilized, and which was hardly heard of earlier, but now it's you hear it everywhere. So for example, in our own clinic, 30 years back, if we had a patient of child with autism, it used to be a clinical curiosity. We all used to sit and examine the child and then make it a case presentation. It used to happen once in a month or once in 2 months. So it used to be very, very uncommon. But nowadays in our clinics, we see at least 2 to 3 children with fresh cases of autism every day. So there seems to be definitely an increase in the prevalence. Now, how do we account for this increase in prevalence? There are a number of hypotheses, a number of theories. So it's still not clear, but one can not straight away attribute it to true increase in the true prevalence of the disorder. It may be better awareness, it can be dilution of the diagnostic boundaries, or it could be diagnostic substitution. What used to be called as other disorders now is more likely to be called as autism. A number of these factors, or a combination of these factors, could also be responsible for increased prevalence of autism. So that is the second neurodevelopmental disorder for you. The third one, which actually affects many more children and which is very hidden, and which is getting more and more recognition nowadays, is the specific learning disorder. Now that there is universalization of education and children are supposed to do well in school, any deficits that they have in learning, either reading, writing, mathematics, or spelling, tends to get picked up, and its prevalence is really very high. It's probably the commonest form of neurodevelopmental disorder. And probably, if you just take very clinically significant severe forms of specific learning disorders, it's at least 2%. So, and if you add the milder forms, it may become 5% or 7%. If you take scholastic backwardness as a whole, it becomes 10%. And what is more important about the specific learning disorders is that it leads to a lot of secondary impairments and disabilities and secondary mental health problems, emotional and behavioral problems in children, because they come under a lot of undue stress. They are blamed for their scholastic backwardness. They're called as lazy. They're called as stupid. They are called as, they are made ridicule, and they, are sometimes grilled, for, let's say, 15 hours, 18 hours per day, so that they can do well in studies. And how do they respond? They respond by becoming distressed, by becoming unhappy, rebellious, develop all kinds of problems, and that becomes the focus of this presentation. So we find this kind of a presentation very often in our clinics. So now we have that as the other group. The next group is the specific developmental disorder of speech and language, in which all other things are okay. Child's cognitive development is okay. Child is very bright, and the social interactions are really good, unlike in autism. But the child has difficulty in developing and using language. So it might be, it's very often it's expressive language. Child can understand a lot of things, and they know hearing impairment, and but still the child can't express himself or herself well. So this is specific developmental disorder of speech and language, or developmental language disorder. And very often many of these children continue into later childhood as having specific learning disorders of learning disorders, by which I mean reading, writing, mathematics, and spelling. So there is some kind of continuity between language impairments and learning disorders, specific learning disorders. In addition to these 4 core conditions, there are a couple of other conditions which have been added to the list of neurodevelopmental disorders, basically because they all have, both of them have onset during early childhood, both of them tend to persist for long periods, often for a lifetime, and also they can be conceptualized as lack of development of a particular kind of skill or competency or certain aspect of development. For example, you have attention deficit hyperactivity disorder, which is now conceptualized as a lack of development of self-regulation. These are children who don't develop self-regulation like other children, and most of the symptoms that they have can be attributed to this lack of development of this particular capacity from early childhood. The other one is chronic tic disorders, and this is lack of development of control over motor activities. So like this, the list is growing, and then there are many other conditions which are getting added. So now overall, what is the importance of these neurodevelopmental disorders? Their importance public health importance derives from the fact of their increased prevalence. I mean, if you put them all together, they are high prevalence conditions. And therefore, obviously, and their persistence, many of them persist for the whole lifetime. So that is the second reason why. And thirdly, the impact of these disorders on these children and their families is enormous. I think Dr. Mahesh mentioned this in his presentation. The impact of this disorder, I mean, the impairments in development on the child and on the family is enormous, and that's why it requires a lot of attention. So now, so what is it that we can do about this? There are a number of promotive activities, for example, universal iodization of salt, or improving the nutritional status of adolescent girls even before they become pregnant, because it has been seen that preconceptual weight of girls has an impact on the birth weight of the child. So weight of the child at birth. And that has significance for development. So it's a transactional kind of relationship. So a number of things like this, health promotion can be done, and specific protection like immunization and things like that, improved safe pregnancy, safe perinatal period can go a long way. Other than these things, which are of course well established, and a lot of things have happened in that area, is three things which I feel are very important. One is developmental surveillance. We all should become more and more aware of the developmental milestones and the importance of paying attention to, and monitoring the child's development. And it is the job of the whole society. The developmental surveillance involves all the stakeholders, including parents and health staff, whether it is frontline or whatever, specialized people, and even during the well-baby clinics. If somebody, if the pediatrician or the health professional asks, how is the child's development? How is he developing? How is she developing? So the green flags and red flags of development, people should know and then ask about it. And if there are impairments or if there are developmental delays, they should not be ignored. So then one should move into the area of at-risk interventions. See, very often what happens is when there is certain amount of delay, parents wait, but their concerns do not, if it doesn't get resolved, then if it persists, then the health worker or the pediatrician or the doctor may, chalo theek hai, thodi der wait and watch policy. That's not, don't wait and watch. Start the intervention, even when the child is showing minimal developmental delays. That is the current approach. So, because that is the crucial period where the plasticity of the child is there, brain is there, where inputs into development can get the child out of the risk into the typical trajectory of development. Then the next thing is those children who have established developmental delay, early detection and intervention. If there is one thing that I have seen work and which I think should be practiced with any child with showing significant developmental delay of any kind is early detection and intervention. And this is something which is eminently possible. And the technology of early detection and intervention is not really so complicated. And it can definitely be delivered by even at the primary healthcare level. So now, how does one do this early detection and intervention? I think, to my mind, the most important approach is home-based, parent-mediated early intervention. So you teach the parents about how to train the child at home, and with a lot of incidental teaching that happens at home, the interactions between the mother and the child can foster development in such a fashion that the impairments become lessened, and many a times milder disabilities or milder impairments, in fact, can vanish also. Then, of course, the interventions or the management of neurodevelopmental disorders in general and specific disorders in particular is, many of them, it's a lifelong process. So one requires a lifespan developmental kind of perspective, whether it is the emergence of puberty, sexuality in adolescents, or whether it is issues about education in early, before that, in school age period, or whether it is the issues of diagnosis, confirmation of the degree of disability, the causes, and the reproductive decision making or genetic counseling, or identifying treatable causes. Different stages bring in different challenges, and we all need to respond to these things. Thank you very much for this opportunity.
Any questions, please? Otherwise, I will go to next. I request Professor Muhammad Abu Salim. He will speak on alcohol and substance abuse.
I must say I've never been in a conference with such an audience. I admire your endurance and staying powers to say, we should have finished, well, a half an hour ago at least. But there you go. I was approached by Vimal to give a talk, and we did some talking also in Lucknow. Unfortunately for our session, there were only 3 or 4, so that's fine. You're here. I chose to talk about substance misuse because this is my specialty. But more importantly is that I've recently discovered a superb, powerful, effective package which is all computer-assisted, internet-based intervention for alcohol and drug problems, which I wasn't aware of. And the reason being is that addictions in the UK have been taken over by the third sector and partially by the private sector. Now, the non-stat agencies involve people with lived experience, ex-service users, recovered people with alcoholism, drug addiction, but also broad counseling and relational skills that focus on recovery versus a biomedical model which really focuses on diagnosis, treatment, including medication. Sorry. But before we start introducing this, I'll end up with a 3-minute video which will explain it all. What's happening? Well, I think we're living in a digital age, or if you call it, maybe this is the digital century. Our lives has been transformed completely and radically with unknown, unforeseen consequences. But I'm optimistic as by nature, and I think that's only good can come out of this. And you can see that we are all connected 24/7 worldwide at no cost. So here we are. We're thinking we should use the technologies. And this is a document from the King's Fund, which is a charity which shapes health and social policy in the UK. Came out, this is 2016, the digital NHS readable document. You just download it from the, does this work? Yeah. I'm not going to go into details, but you're starting with electronic health records and, of course, ending with more advanced uses of the technology. And talking about electronic records, in our trust in Southwest London, we've been a paperless electronic record service, mental health trust, for the last 10 years. And you can see here, comparison, sorry, you're pressing this. You can see that looking at acute trusts, acute medical services, ambulance services, community services, and mental health trusts, which are specialist trusts, the majority electronic notes being adopted by mental health trusts. This is the only area we are more advanced than acute trusts. My son is a consultant diabetes in the cardiology in Newcastle Teaching Hospital. They don't have electronic medical records. So we are far ahead, and we should be. National Institute of Health and Care Excellence, which is known to you by NICE, has just come out in December last year with evidence standards framework for digital health technologies. So they are setting the standard for this, what works. Of course, we all know that the gold standard is randomized controlled trial. They're saying, of course, we should subject any intervention, any technology to such tests, but there are other methods and methodologies to be adopted. We should be more broad. I'm not going to go into that. Again, that's not. But this is important. The Lancet, which I think by all accounts the best medical journal in the world, and is very interested, of course, in global health and issues. We see many publications. But this is this month, January, came out with another Lancet about digital health. And you can see the topics there. A long list of topics. It's not about just telemedicine. You can look at the list where it ends, and they're calling for papers. So this will be the first issue within a month or two will come out of the Lancet Digital Health. So if anyone has got a good paper, go for it, okay? There's maybe there's no competition, but I'll be surprised. So what about my service? I work with a mental health NHS trust service. It's the only drug and alcohol community-based service in the trust,
because we lost all our services, including our alcohol inpatient unit, drug inpatient unit, to the third sector. So the only service which was this, because it's of its excellence and for the vision that we should work in partnership with the non-statutory sector, which has taken over all addiction services over the country. So, and that had serious impact on training the future addiction psychiatrists, which no longer exist. But anyway, our service has been rated excellent. Now the CQC, the Care Quality Commission, which is the regulatory body for all health care and social care in the UK, gave us an excellent rating. Now, as you know, for those in the UK, this doesn't come easy. So it's because we managed to integrate the clinical element of our services, doctors, nurses, including physical nurses, with the psychosocial approach of people who are coming from the third sector, who are very recovery oriented. And you can see here from this, the extensive, and comprehensive psychosocial therapies available for alcohol, drugs, and specific ones, including dual diagnosis. And that's, I say, the essence, the mainstay of treating addiction is this, which is often neglected. Of course, we need to diagnose these people, we need to treat them, do assisted withdrawal, whatever, but in the end of the day, the mainstream or mainstay is psychosocial. So what about this? This is called Breaking Free, and it's free, dedicated to help people with substance dependence through digital innovations using behavioral science and clinical impact. And I'm not going to read all this in great detail, but it's, in summary, you're targeting, clients, as we call them, not patients, who are engaged with community alcohol and drug services. We're targeting clients with alcohol drugs problems who are accessing the criminal justice system, would be the police, the prisons, probation services, where many of the drug addicts, of course, end, and also addressing smoking. So it's very comprehensive. And the methodology, as you see, is quite comprehensive, but more importantly, personalized recovery-oriented, or package that is accessible 24 hours a day. And you have a list there, comprehensive, addresses dependence for a wide range of substances, complements and enhances existing approaches, operates at a deep therapeutic level by looking at the underlying psychological issues that cause or contribute to occurrence of addictions, utilized by patients in self-directed way, etc. And targets all these substances, including tobacco and all these new psychoactive, of course, which are not listed here, etc. So all these drugs are there. But the focus, of course, is about, class A heroin, cocaine addiction, alcohol dependence, of course, smoking. So, and for the technology, you use, tablets, laptops, smartphones. And it's, as it says here, there are a lot of products there which can be printed, output, monitoring the changes that is taking place in the life and the journey of the client through their treatment. It augments and in sync with the Break Free Online, and strengthens relapse prevention by nudging patients via alert and etc. Okay, of course, it concerns commissioners who purchase the services, concerns the organization provides services, and concerns clients. And it provides information to enable commissioners to evaluate the services that are being provided. Sorry. And importantly, it's been accredited by NICE, Ministry of Justice, the Her Majesty Prison Service, by university departments, and also Oxford, Cambridge, Royal Society of Arts, and then in Canada by Ontario Telemedicine Network. Okay, of course, it involves assessment and identification of the problems before moving to what might be of help. And to this date, there have been 26 peer-reviewed publications emerging from this. So it's all rare. The evidence is out there to be seen. And I'm happy to share these slides, but also all the publications that you emerge of this. And it adopts the lifestyle balance model with its 6 domains. You can see from the graph here, its lifestyle, starting with, of course, you can see difficult situations impacting on engendering negative thoughts, negative emotions, physical sensation to do with drug effects or withdrawal effects, and unhelpful maladaptive behaviors. So that's the essence of this, plus being, utilizing the recovery progression measure, which assesses biopsychosocial functioning. I have no credit with this. I found it out. We are adopting it. We're going to start training our staff, within the next month. So, you can ask me any questions, but I'm happy to, tell you where to go with this. So it utilizes the information in this way, but I will show you the video, which I think which explains it better. And looking at the scientific basis, it has a robust behavioral science base, which includes the following list: psychoeducation, self-monitoring, cognitive restructuring, motivation enhancement, mindfulness, you name it, it's all there. And there are several conceptual papers. This is not just hearsay. They are the detailed, thorough analysis of the underpinnings of this intervention, utilizing all these technologies or sciences. And it also provides outcomes in terms of improvement in the alcohol problem, the drug problem, improvement in health in general, quality of life, improvement in mental health, anxiety, depression, psychotic symptoms. All that you have is there to be seen. And it's been shown to be effective in severe addictions to opiate and crack cocaine. Here it talks about it leads to 65% mean reduction in weekly alcohol consumption, and is effective in improving alcohol dependence, anxiety, depression, quality of life, recovery progression. These are just snapshots from papers, and also effective for dual diagnosis patients with complex needs, which is always a great challenge, and the people who fall between the cracks. And also effective in for offenders in secure environments, as I said, prisons or police cells and what have you. It's been adopted by the third sector and led by, this is the largest third sector organization called Change, Grow, Live, and actually were fueled all this research. And there's been comparative analysis of comparing 500 patients receiving this treatment as usual versus this intervention, showing that the intervention works. So I think I covered the key elements. So this is now, we show you a 3-minute video, which I think will perhaps conclude my presentation. Can you do that, please? Yeah, community. You have to log in, of course, to access the package.
At the heart of breaking free is a diagram that shows you what's keeping your own difficulties going. This diagram is color-coded, so you can see how these issues are affecting you at the moment. Red areas are having a major impact on you, so you should definitely focus on these. Amber areas are having a significant impact, so we suggest you tackle these too. And although green areas aren't having much impact on you right now, focusing on these will build your resilience for the long term. By using this switch, you can move between this diagram and a personalised one that's unique to you, as it shows the particular challenges you're facing in each area. To work on any area, just click on it and you can instantly access 2 strategies. The first is an information strategy that will explain how any issues in this area could affect your recovery. The second is a practical action strategy that will give you the essential coping skills you need to resolve your difficulties in a lasting way. Whenever you complete a strategy, you'll get either an information summary to reflect on or an action plan to put into practice. You can email this to yourself or download and then print it. All these essential recovery resources will be stored in your toolkit, meaning you can revisit them whenever you want to. You can keep track of how your recovery is going on your personal dashboard on the home screen. And you can update this at any time by clicking here. This will give you a progress report and a certificate showing everything you've achieved. Just use the main menu to go straight to your dashboard, your diagram, your toolkit, and a number of other features that will assist your recovery. As well as giving you 2 strategies in every area of your diagram, Breaking Free lets you choose which order to try them out. But we strongly recommend that to strengthen your recovery, you work through all the strategies, and that you set aside at least 1 hour every week to use Breaking Free. This will create a routine and help you build momentum, especially if you log on at the same time each week. Whenever you complete a strategy, make sure you download or print the summary straight away. Then use it between your sessions on Breaking Free. It's essential to reflect on all the information you're given and how this relates to you, and to put into practice as often as possible all the new skills and techniques you learn. The more time and effort you invest in using Breaking Free, the quicker you'll see any red or amber areas of your diagram turn green, and the faster you'll achieve your recovery goals.
So that's it. You must add that there are now packages for mainstream mental health problems with the introduction of increasing access to psychological therapies called IAP a few years ago, where people with anxiety, depression, common mental health problems are, provided with psychosocial interventions, various levels of intensity, that there is now a package, which is computer-based or internet-based for mental health problems such as anxiety and depression, which also have been shown to be quite effective. I'm happy to answer any questions, if any.
Yeah, thank you, Professor Mohammed. Very interesting. Any questions, please?
So, does this information go to the NHS or to the doctor or the person?
Good question. I mean, I should emphasize that research has found that there's been a lot of research on internet-based interventions, computer-assisted interventions. What is being shown is that on its own, it's not going to be easy. However you promote it, whoever is going to suggest it to a client or someone suffering from a health issue or drug or alcohol problem in this case, is not going to take it up automatically. It needs this contact face-to-face with a practitioner or a peer support worker. We call them mentors, recovered addicts, who run these psychosocial programs. So the advice is that you start off with a face-to-face assessment interview, introduce the package to the client, and support them. They might need to come and see you again. They might want to call you or give you access to their mobile phone so they make contact. But in essence, most of the work is done by the client in their own time, in their own space, but you are there to support. So that's very important for the client to adhere this and go through until we perhaps another 20 years, we'll all be doing all sorts of things by ourselves. Yeah.
Any more? Thank you, Professor Mohammed.
Thank you.
Thank you, panelists. We conclude this session. Any announcements or anything? Otherwise, today's.
Thank you, panelists, for giving your valuable insights.
We have been listening to eminent panelists deliberating in the areas of mental health since morning. All these valuable insights gave us a new perspective. With this, we have come to an end of this 3-day event. May I request Professor Vimal Sharma for closing remarks? Please, sir.